Bien, bien. Muy agradecido con esta gentilísima invitación.
Estou aqui em minha casa de Lake House. Não sei se
Ajá.
consegue, não sei se consegue ver.
Enséñame un poquito, dale la vuelta.
Não, está um pouco escuro agora. Aqui são as 6 da
Oi,
tarde.
Marcelo, tô te ouvindo agora.
Beleza, hein, doutor Aldo?
Consegue ver alguma coisa?
Qué bien, mi viejo, qué maravilla, qué divino. ¿Tienes cuánto tiempo allá en la casa?
Deixa-me arreglar essas coisas aqui.
Te dejo.
Deixa um momentico só. Um momentico, esse aqui está.
Dátele.
Bueno, agora sim. Enrique, me contas, como está a coisa por aí? Como está Bernardo? Bien?
Bien, está mucho mejor, todo está bastante mejor. No lo he visto personalmente porque tenemos prohibido ni acercarnos a él, pero sí está mejor. La situación en general está mucho mejor. Hablo con él todos los días, está mucho más fluido el diálogo. Obviamente era algo motor, era broca, o sea, era más bien motor, pero mira, él está bien, él está en términos generales bien y el ánimo está muy bien.
Isso é importante. ¿Y tu familia está bien? ¿Todo tranquilo?
Bien, todos bien fastidiados aquí, tú sabes, sin hacer nada, pero
sí,
¿qué voy a hacer?
Yo no estoy en cuarentena, yo estoy en noventena. 3 meses, tres meses por acá, ¿tú crees? So it's organized many courses, not only in Jacksonville, but in many parts of the world. It's a very international, well-known name. Thank you very much, Enrique, for accepting our invitation and to join us in this international live stream tonight. You have, as a moderator of this section, Dr. Leonardo Balsalobre from ENT Center of São Paulo, Hospital Edmundo Vasconcelos. And thank you very much for all the panelists, Ricardo Donce from São Paulo, Nilvana Andrade from Salvador, Bahia, Carla Meotti from Porto Alegre, Fabrício Scapini from Santa Maria, Rio Grande do Sul, and Maria Júlia Isa from Belo Horizonte, Minas Gerais. Please, Dr. Leonardo, it's your time now. Go ahead.
Thank you, Enrique, again, to accept our invitation. It's a pleasure having you with us. Actually, we are close friends. We are always together. It's a pleasure seeing you. And all Brazilians ENT know you here, and we really appreciate having you talking to us. Well, before starting your presentation, I'd like to ask Camila to explain to the audience how to change the translation, and if they have any question, how to do it. Please, Camila.
So I'm going to explain Portuguese for the ones that want to be listening the lecture in Portuguese. Então, vocês vão encontrar na parte inferior do vídeo um símbolo de mundinho. Nesse símbolo, vocês vão encontrar off, inglês ou português. Se vocês colocarem no inglês, vai estar no canal original. E se vocês colocarem em português, vocês vão ouvir a tradução. Tá bom?
And another important point, I think it's the microphone would stop for everybody, right?
Yes.
Okay, that's good. That's good.
It's muted. And if someone has a question, we have a Q&A. Would like to ask you to make your questions in Q&A, and after the presentation, we're gonna select some of them to ask Enrique Iturriaga. Enrique, thank you again. Take your time.
Thank you, Leo, and thank you, everybody. Leo, just a quick question, or Camila, do you see my screen? Do you see the first slides?
Yeah,
okay, perfect. Okay, thank you, guys. Well, and again, thank you guys for this very kind invitation. I really appreciate, and you know what are my, as you were saying, not only the friendship, but my feelings for Brazil. Okay, so I miss you guys here. You know, you are the dream team that we used to have our courses like many times a year, and you know, we're all stuck here in our countries waiting for better times. So hopefully everybody's safe. And what I can tell you is that I really appreciate this invitation. On the other hand, I want to thank Aldo again. Aldo, again, thanks for always thinking about how we move things, because Aldo, even he was the one who chose this subject. I really appreciate that, Aldo. But again, he's probably the one who has to be in this subject, because I believe that Aldo has been the guy that has been in innovation from the past 40 years. He has been around looking for things and always trying to innovate. So that's gonna be the subject, but I think it was a transposition, Aldo. You want to do it your own, but you gave it to me. I'm really, it was very kind from you, okay? On the other hand, my disclosure, I'm also, director or medical affairs director of Medtronic. I don't think that any of the things we're going to talk have any, a special particular effect on anything. So probably we're going to take very general ideas that I organize in here. So with that, let's start the presentation. And again, I just want to set out a point. Innovation, that was the name that they gave me for this presentation, is different than invention, okay? Let's just get into that. Invention comes from the fantastic world where you can probably create very cool things from nothing on the back, probably. But innovation is something that has some basis, and you're really bringing something extra or trying to add on, on all this evolution of things. So I choose innovative technologies. So as you understand, I'm just gonna talk about the things that we are really improving, things that we know we have been doing. And probably 90 or 99% of the things we innovate. We do things that we change, but things were done almost always at some point were done before that. So innovation by definition is what you're reading here, an idea, process, or device originate after study or an experiment. So it is to learn and evolve. And although I couldn't find any older picture from you, okay, I'm sorry, okay? But I know Aldo from 1990 something, but at the time we didn't have cell phones. So that's the only picture. But what I mean by this is these guys, this huge team that we have here in Brazil. I mean, you're unique guys. You have always been behind how you are the leaders and you lead on your, not only your country and your continent and in the world. So Aldo is obviously the person that we need to recognize the things the way they are, okay? So I divide this presentation in 3 different aspects. And by that, I didn't mean that I'm solving all the things. Innovation has, that's infinite other different sectors of subjects that we can treat. I choose to talk about innovation in knowledge, in education, and in surgical technology. And by the way, we can agree that I'm missing here a lot of things. And I did a lot of things in purpose because in 1 hour, we cannot cover everything. So basically, that's how we're gonna talk this, okay? So let's start one by one, the way I organize the ideas. So basically, in the knowledge, I just wanna bring something that for me is a key thing, teamwork. I believe that if we talk about innovation, and I remember the way I was trained a long time ago, probably one of the most revolutionary things I've learned on my own in my life, and I have to pass to others, is teamwork. All divisions there were specialties where we couldn't step there. It was not about competency. It was about there's a sector limit, you don't cross from there to there, has totally been obsolete, okay? Nowadays, it's about who gets trained, and obviously, nobody can have all the truth on the inside. So having a teamwork and dealing, I mean, even the reception of the patient, even everything you're gonna treat on the patient, even the diagnostic, even the way you decided if it's a medical treatment you're gonna bring or a surgical treatment, and the postoperative has to be built around a teamwork. So I totally believe that this is just one example. In skull-based surgery, I believe either neurosurgeon, either orbitoplastic, either maxillofacial, or all of them together, endocrinologist, whoever is on the team has to be part of that. And that's ridiculous. I mean, we're clear nowadays that the main subject, the main objective that we have here is the patient. And for that, the only way to reach to the patient in the best way is to have more competencies working around. So that improves the outcome. I just want to bring some details. And I mean, in the knowledge, I believe that if I compare what I was doing and what I'm doing through the years, one of the things that really impressed me is how detailed the anatomy became. I mean, I used to study like all of you guys by the Testi or the Latarjet or the whatever, Rouvier or the Gray's Anatomy and things. I mean, this is not exactly the anatomy that we are using right now. And remember, if anatomy is still the same, the perspective of the anatomy is not the same. What was something medial now probably is something lateral, or vice versa. I mean, the carotid was something that was deeper. Now it's probably something that you face before other structures. Essentially, we have changed our perspective because we have changed the tools, we've changed our approach, and that brings a lot of differences. And again, one space now becomes, you know, a 1 millimeter space, or 10 square millimeters becomes a huge space whenever you're dealing with some augmentation of the tools that you're using to. So we need to understand that this is a highly detailed anatomy that has to be approached and learned in the new perspective that we're doing the things. And again, the fact that now we have the data, we analyze the data, we can see the patients inside the patients without opening them. I mean, we can have a CT angio, we can see how the vessels are, and we can see how are the anatomical variants, how we compare in a big population. So we can do a lot of things, and those things have changed. Even small little spaces, small little paracellular ligaments that didn't have any relevance, and now this is an approach. You do a middle cavernous approach, and these small little paracellular ligaments becomes part of your landmarks for anything. Even small approach or approach around some arteries, at the point that long time ago we used to take away a tumor. Nowadays we create approaches, and the approaches we select. This is a branch that mainly is supplying a very functional area like the chiasma. So the approach has to preserve some branches and sacrifice some branches. Kind of things that now we're needing very, very granular. And I think this is part of the refinement that we have found through the years. What about the surgical techniques? These views are from an intraconal anatomy. Even some spaces that didn't exist, or virtual spaces, now we can make those spaces and create some anatomical areas that we can approach and we can use as an approach too. So the orbit is something which is really, really something that, I mean, we never thought that the orbit, we knew that the orbit was the field of the orbitoplastics, and that was for treating tumors inside the orbit, but we never thought the orbit as an approach to get to the ventral aspect of middlecranial fossa. So these are kind of things that have totally changed, that now we use the anatomical corridors in order to get to some areas, and we combine them because now we know more. And as we make teams, we can have the competency of an orbitoplastic that let us know how to use this an approach without harming any structure down there. So just to mention new approaches, you know, we have the transnasal, lacrimal, intraconal space, but one of the things interesting is this concept of multiport approach. I mean, if we have different ways, we have different tools, and we need now to be exhaustive to treating the tumor because we understand the 3D projection of the tumor. Now we can use different approaches through different specialties, trying to deal with the tumor, which is, again, a great option. And I think this is unique. What about this transpterigoid approach to parapharyngeal space? We used to stop our dissections, I don't know, at the level of the emergency of V3 through the oval foramen. And now nowadays we can go anywhere. We can look for, I don't know, jugular foramen or anything like that. So basically we have learned a lot about this new anatomy because we have the right tools, and we want to comment around that, okay? Okay, let me not only at the level of knowledge, there's also new technology for diagnostic. And that's a very interesting thing too, because yesterday I'm gonna just mention something, but you know, the light can be divided according to the different, you know, you can use filters and you divide the light and you see the way the light can approach some structures. And according to that, you have some refringence that might be altered by the composition of the tumor or whatever you're looking at. One of the most used things is the filters of blue and green light, okay? Because it shows a lot about the mucosa. You can make the differentiation between the mucosa and what is not a regular pseudo-stratified mucosa. Now you can see the difference between what is really a tumor and a mucosa and what is the limit in between them, which is something that we need. You know, the margins of the biopsy or the margins of the resection can be deal with that. And now we know that, and we're gonna talk more about this in the virtual things that we're gonna keep talking. On the same subject, in the diagnostic new technologies, I really like this, which is called the NIRAF, okay, near infrared fluorescence. It's something that it is really, really pushing because we've learned that, and I don't know how to call it, because it could be almost augmented reality at some point, and I'm gonna let you why. Because you're seeing the same things, but you're seeing differently things. And you're seeing differently because one of the methods that we use is called the SWIG. It's called the indocyanine green. We use that colorant, and we use whatever you wanna use, plus the near infrared fluorescence, plus the indocyanine green, and you can identify the differentiation between the carotid and the rest of the tissue. And it totally lights up totally different. You can see the functional pituitary and the non-functional structures. And you can use the same technique even for gliomas, meningiomas, and a lot of structures. So now and again, you don't have to turn off in and off the light of your OR whenever you're doing these procedures. You can use this kind of technique of infrared, the NIRAF technique. You know, it's not a new thing. It has been used for parathyroid, it has been for other tumors, and now we're bringing that to endoscopic skull base. And basically, I think these are real-time way to know exactly what the structures that you have around might be the ones, okay? There's another, if you don't use indocyanine blue, but you use a 5-aminolevulinic acid, I mean, you can have, you know, a very nice color for meningiomas and chordomas, because this colorant might be taken by the protoporphyrin 9, which is a precursor of the hemoglobin, or the hem part of the hemoglobin, which has iron and porphyrin, and it's absorbed, and that's how it lights up the meningiomas and the chordomas, which is great. I mean, if you have to resect tumors, and you know, we at some point we are clear about the limits, but whenever you're in a surgery, you lose the perspective in a lot of time. So that is a good way to understand where we're dealing with. On the therapeutic side, I just want to mention something that probably you've heard that from Japan. In Japan, it has many years. In US, has not been very used. The heavy carbon ion radiotherapy, it's coming to US right now. And it's something that is super expensive, that, you know, cost benefit at some point was pretty questionable. But in US, we have 3 centers, I believe, at this point. But it is something which is really interesting, because if you compare, as you see, it is a very strong radiation. You compare, you mean the carbon ion, I mean, 3 ports of carbon diet makes what the X-ray might be with 9 ports. So it's a very strong, and the diffusion is very high. Take a look on this publication that's in Germany, and this is a chondrosarcoma, and they have controlled 632 patients. I'm not going to jump into details, but the control at 5 years, it's pretty high, the rate of chondrosarcomas and chordomas, which is amazing, this control and survival rate. And basically, this is something that might change our approach in such a different time to time and difficult tumors. So basically, these are the new things that probably are going to change our approach to many things. But I don't want to jump just into the things that are really more focused on the skull base. I just want to go also to the basic things, because things have changed even in the simplest way, okay? Let me just remind you the big, earthquake that we have when somebody start talking about the microbiome. I mean, we were trained a long time ago according to the fact that the nose or the sinus were totally sterile, and whenever we have a culture positive, we kill the germs and whatever. So now we know that, you have 1 million bacteria in 1 square meter of air, okay? And you have tons of bacteria inside the mucosa. We call the commensal, and there's a balance, what we call the symbiosis between the pathogenic ones and the good ones, the probiotic ones. And what we have tried is to make a systematization. So try to find out, okay, all the humans have the same kind of population of bacteria. And we found that there is a lot of variation between body regions, between sociocultural people, between ages, between sex. There's a lot of variation on that. But basically, we know that we live with bacteria, okay? And we know now that when we have a disruption of this balance of the bacteria, this is when we call a disease. Could be acute, could be a chronic disease, because this balance stays for a long time. But on the other side, we have to understand that the antibiotics, which kills everybody on the way. I mean, if you take any penicillin, it might kill coco, bacillus, gram-positive, gram-negative. I mean, and you're really cleaning most of the bad ones and the good ones. So basically, that's why we need to question what is our strategy, because probably now we have new things coming on the way. So on the other hand, I put this slide just trying to remind you that now that we have COVID and most of the patients, I mean, the biggest complication as a lower respiratory airway is a pneumonia. Basically, part of what we got on the lower respiratory tract comes from the upper respiratory tract, as we know. Okay, so it is clear that we in the ENT area, we have to be very clear about the balance when things are okay and when things are not okay. How do we recognize when the disbalance situation is coming into the play? So part of the microbiome, it's very cool to understand that when we're born, I mean, we start acquiring our biome through the first year of life, okay? Still have a lot of variability between individuals, but we still have, this is part of the normal bacteria that you have, what you're seeing on the right side, okay? Let me just give you what brings a swab. When you do a swab of the nasal cavity, you got 4 million, okay, of fragments of these different bacteria. So that is a lot, okay? And something funny that I found that I never knew about it is that women have almost half, okay, of the density of bacteria in their nasal cavity than we have the men. The classical ones that we have are Corynebacterium, Propionibacterium, Staphylococcus epidermidis. These are the ones, but we have the other ones that you have on the right too. And how then, if we live with bacteria, how do we get disease, which is something that we would love to understand. And all these questions that we have here, we have some intellectualization, rationalization, as we call it. We have some ideas, but we don't have like the proof that this is totally clear, because we don't know what the host factor can do, what the vector, why some vectors are susceptible, while others are not, what the climate can do, the height, humidity, temperature, pollution, cigarettes, whatever you have. We don't know exactly how is the influence. We know the influence, but what we know, and we do know for sure, is that there are some things that might change, okay? And I just wanna bring these things. We all recommend our patients, nasal rings, okay? That's probably one of the things we know. And we know that perfectly these nasal rings washes all all these inflammatory cytokines and inflammatory things. So it gives you the chance to recover the new tissue. And that's part of what we do. But we know that one of the things, okay, that might happen during a chronic rhinosinusitis, it is that we have an increase of Staphylococcus aureus. And the most interesting thing is that this decrease in Staphylococcus aureus and increase also in Pseudomonas might deplete all the rest of the bacteria. And I'm going to show you some of the experiments that try to show the correlation one to the other. That's something that we have been following, to put some probiotics in the nose. They did this experiment, putting this whatever lactobacillus for CRS in 77 adults. It failed. They did another lactic acid microbiome. It fails adults. But something which is amazing, in the kids with IRS, acute respiratory syndrome, they have been treated with Enterococcus fecalis in some washes, which sounds totally horrible, okay? And some lactobacillus, and they have even improved their chronic condition like asthma. So that's an amazing thing. So that's things that we need to understand. That. So what happens when we use at least, you know, something like mupirocin? We know that we disrupt totally the Staphylococcus aureus. That's a fact. But the problem is that what we have learned is that Staphylococcus aureus always comes with the Corynebacterium columns. And the Corynebacteria columns, which is the partner of the Staphylococcus aureus, secrete acid oleic and acid linoleic. And these guys reduce the presence of Streptococcus pneumonia. So basically what we have bad guys with some members on their own gang that control the other guys trying to do things. And that's the way we get the balance. And this is what we call a long time ago, the quorum sensing on these external biofilms and whatever. It happens inside the tissue with the bacteria. They talk to each other, they control each other, they secrete some substances. And that's the way they always control what they have. Something interesting is, for instance, this pneumococcal vaccine, it increased the MRSA infections, okay? We know that this pneumococcal vaccine can increase, okay, a lot of bad things, okay? And essentially because, okay, it has shown that Staphylococcus aureus could increase on that. So basically, these are the things that we don't evaluate. When we do something against something, probably we are changing the balance that has to be the optimal balance. I don't want to go into these details but I found this pretty interesting because these are simple things that we do in our day-to-day things that doesn't mean very complicated thing that has changed and we don't see them, okay? And again, I'm impressed that, for instance, let's say in this case, this vaccine decreased Corynebacterium. And if you decrease Corynebacterium, you increase Streptococcus pneumonias. And if you increase that guy, also Staphylococcus goes down. So you disrupt the situation one by one. So there are a few things that we need to understand on the long term that we didn't know before. And again, we knew before things, but we never really look at those very little details that might be connecting one to each other. On the other hand, what's new again? On the surgical side, something interesting is that, you know, we disrupt tissue when we operate or not even operating. I mean, when we get a chronic inflammation, there is a disruption of a normal epithelium. The same happens whenever you are doing a surgery, okay? So we know this, are the different phases of the tissue health. And basically what we need to understand is that we can act or we can react or find solutions for things in order to treat the different phases of the healing procedure, okay? So I'm just gonna mention about some of the biomaterials. 25 years ago, we started using some pack and we have all kind of packs, you know, guys. We have used in the different time, different packing according to what was available at the time. But I remind you, this was the classical pack at some point, then became the era of the hyaluronic acid. So we start having the first generation of hyaluronic acid, the second generation hyaluronic acid, the third generation. And every time we were getting a little more perfection on what was more on the, you know, on the inflammatory part or was more on the bleeding part, trying to control the different variables that might affect the healing of the patient. But new things came. And then we got, you know, these derives of the polysaccharides, of the shell of the seashell, the chitosan, and here we have the flow seal structures. And according to what you're looking for, we have now this menu of different kind of alternative, the biomaterials that we have according to what are our needs. And one of the things we have to learn is, you know, we use a lot of, when we have bleeding, we use a lot of this bovine gel plus thrombin. And when we use that, you know, these make a more fibrotic cavity. So the healing is very good to contain the bloody part of this immediate situation that you have, but then you have to deal with the fibrotic part. And again, it's a trade-off. Like everything in life is a trade-off. We don't have the perfect product yet, but something that we have to think about it. So on the other hand, I just want to mention what we do. Okay, what about CRS? What is the spectrum of the things we do in CRS? And basically what we do is basically surgery. Okay, and we know that what we call CRS is a big sac where we have different phenotypes. And if you look for these phenotypes, we know that, you know, when you operate a CRS with polyps, the recurrence rate is pretty high, 40 to 60%. And if it's without polyps, you might have 10 to 20%. So obviously they might be in that big sac, different compartments, and we can talk to the patient differently, and we probably can address the patient differently. But we have been doing the same things for the same, because we call it the same way. And now we know that how we're going to differentiate these kind of things. So, but basically what you learn from that is, if you have recurrence rate for 40 to 60% or 10 to 20%, we're not curing 100%, okay? We're not curative. We're doing our best. And according to the pathology, we have better outcomes time to time, but we are not doing the perfect situation. So what can we do extra? So we have, you know, the new things that are coming, trying to catch up on these healing phases of the recovery of the epithelium. And we have what we call stents or implants. You know, the difference, it's mainly the time that they're gonna stay there. And one of the things, you know, again, it's a trade-off, as I was saying. You can really watch your patient, you can use a balloon, you can do a functional surgery, you can do a full house FES. So you come from a very conservative thing to a very radical position. But again, you know, here, if you are going radical, you know, probably the recurrence rate is gonna decrease because you're taking a lot more of the tissue. But if you are radical, the scarring problems are gonna be worse. So again, it's a trade-off between two circumstances that we have to understand. And again, that's part of what we talk to the patient. That's why we explain to the patient, visit us for a long time, because he has a chronic situation that we need to control through the time. But again, that goes also according to what are the perspective that we're seeing in this patient, okay? If the disease is too advanced, whatever. So what I wanna also is try to bring you the idea of when we go really, this is for instance, a balloon. I took these pictures from a balloon 30 days later and 11th month later. I mean, if you're really conservative and you make small openings, and this was not the right patient, it was not an obstruction, it was more an inflammatory thing that might require a bigger, you know, treatment. If you do it wrong, you took the wrong decision, you're gonna get in trouble. So what I want to just bring you is what we're thinking that has been one of the big changes that we're seeing in you know, on the current practice of the day-to-day kind of patients with CRS or inflammatory process, is trying to use some sinus stent that might last with mometasone for a long time. Okay, and I think these are pretty good, have been pretty good on the time. Okay, I again, we cannot expect to correct things that's only trying to delay or trying to catch up. Here is where when you position one, and again, what you're gonna see, this is not a perfect cavity, but again, it's what I was gonna show you before. It was a comparative, but I took some slides off. But the comparative, when you don't use it and you use it, and again, it's you cannot compare things that are never the same, but basically you can get an improvement on the healing process if you stay longer with something that controls the healing process. So that's basically the concept of this, okay? So I just wanna bring this, you know, the fact that you have a nasal spray, you spray the patient or you wash your patient, it's gonna last for a very short time instead of having a continuous, you know, stand with a lutein implant that might stay there. And this is part of their studies. This is not, I'm just replicating what has been shown by them. You know, apparently the fact that if you choose, you know, degree 2 polyps, and apparently they have reduced the improvement of polyps, the revision kind of surgery, et cetera, et cetera. This is something that has been shown through the RESOLVE study. I'm just replicating what they said. This is basically in the frontal. Whenever you use this stent, apparently, you know, the permeability is stayed longer, the diameter is bigger than whenever you don't use the stent on the other side. So I'm just trying to replicate part of the good data that we get from them, okay, the reintervention, the restenosis, the need for oral steroids, everything has been decreased if you use local treatment. And that's an interesting concept. I'm not sure that we're 100% there with what we got right now, but the idea is a very interesting thing. Try to change something that systemically we were giving to the patient and we know it worked, but has a lot of side effects, to something that is more local. And that's a very interesting thing. So on the other hand, I just want to bring you to the field that probably we have been working, and I really want to thank Aldo, Leonardo, Tepedino, Rodrigo, all of you guys, because you have been the ones who has pushed us to move in this direction. I mean, the education, you have shown us that through this way, and we have been there for many years doing this, and we learned that education is not only educate, but there are good ways to educate, there are better tools to educate, and that's why we review all the time how we can improve that. So every 10 to 15 years, there's a shift, okay, where people start interacting totally different with the technology. This is something that comes from Google, and basically it has been the story. The story has been like that. Every 10 to 15 years, something totally changes the way we are gonna use the data and the communication. So immersive realities are basically, this is a big name that covers virtual reality, AR, MR, and 360 video technology. So this is the new technology that we have to offer, you know, and now that we're in COVID era, you know, the digital world and being through Zoom all around the world, that's something great. But again, we can improve that by far. And what we're seeing, there are a lot of opportunities in that field too. I'm just gonna show you something that, this is for, okay, the NIM, it's a product that where you can train people away from you. And you have these simulators, or what we call e-trainers, and we can train the people, we don't have to be there, but they have a simulator on their, I mean, on an iPad that we give to the people, and they get trained for the tool. You can do the same with the surgery. You can do as much as you present scenarios, you train the person properly like a pilot, okay? You have these simulation training things. So this is a very interesting thing, trying to train people as far as that is not gonna cover 100%, you know, it's just a part of the training, but that can do a lot, having the proper e-trainer tools, okay? So the goal is to merge reality, virtual reality, and interaction. If we can merge all of that, that would be great. And that's part of what we're trying to do in trying to find a way, not only on the training side, but also on the pragmatical side, on the OR. And that's basically what we will talk about right now, okay? So the education, now we're gonna talk about virtual reality, augmented reality, and mixed and hybrid reality. So virtual reality is what you got here on the left, okay? What you got here on the left is something that is totally virtual, okay? It's the avatar of something that is totally created, okay? Digitally created. And the reality is what you have on the right, okay? This is exactly what you have here on the right, okay? This is what you see, okay, on your scope, okay? There is no magic thing. So education can take advantage of all this new technology for training people, and we're there for sure. So virtual reality is when you recreate totally, okay? Digital recreation, okay? The computer controls everything, but augmented reality is when you overlay the reality with the other one. And mixed reality is not an overlay, but anchors virtual reality or virtual objects to the real world. And that is the RATOM. This is the ideal one. This one we're looking, the MR, okay? These are a typical example. You have it on your phone, okay? Google Translate, I mean, you can read this announcement in Japanese and you know exactly what it is. It is using the data that you have here to adapt this into this and translate to you. That is very interesting, okay? That is augmented reality, okay? And this is, I don't know if you know these guys, this is a CT scan, and these are some guys that are passionate for that. And as you see, these guys are looking for this virtual reality. He's wearing these glasses, okay? And what he's looking, basically, we have a tumor here that is obviously, you have an MRI that shows you the tumor, you have the reflection of the tumor, but you want to see really what you would like to see. What is the relation? If you do a CT angio and you color the vessels, the veins and everything, you can even see the optic nerve, and you can even see what you have inside the tumor. Where are these different branches? The anterior cerebral arteries, whatever, it's in that tumor, and that might totally change the decision, the approach you're gonna do with that. So having more data, and that's still virtual reality, this is not augmented reality, this is virtual reality based on a CT scan of a patient. But what is important on this is we can try to figure out that it is something that already is preparing us to take probably a better decision in the approach we're gonna do. This, for instance, this is augmented reality. And what you will see here, and just take a look on here, on the left, on the right, I'm not too sure where is it exactly, where we're projecting part here, okay? We're projecting the optic nerves, as you see here, you see the cella here, and you see exactly where the structures are deeper to the image, totally reality against this augmented reality. You can even do some gestures, you can drill, you can do whatever you want to do. I mean, we can add layers. This is only the beginning of something that might be a lot more important than what we think, because you can add layers and you can little by little, as you see, we are bringing into that image the projection of the structures we're not seeing. And that's a very interesting tool too, because this is the beginning of looking and seeing deeper than what we have been looking at. And that might prevent. You don't want to know when you're there because it's too late already. You want to know where the structures are around you before you get there. That's a prevention side of the surgical, attitude that you want to have. So basically, this is what we have. So education can use virtual, augmented, mixed reality, remote collaboration, and this is part of the things we're doing. This is something that we're working and looking at some point. A lot of companies have been working with the HoloLens, and HoloLens has been totally, used by all the companies. If you see here, all the big companies in the world have used Toyota, Airbus, NASA, whatever, they use HoloLens because this is what you have mixed reality, okay? You can have a worker or an astronaut having an issue and just wearing the glasses, and he will project and he will see the virtual image that the guy on the earth is projecting, and he will project the image there, and they can interact, they can move the structures, they can see the same thing, share the same things, and even interact the same active way, like if the guy on the earth was in the ship. So basically, this is the way to go. It's just on a process, but this is the way to go. And by the way, why I'm talking about this here, because I'm talking this on surgery. I'm talking this about training people. We can train people from distance through a lot of technology. So I think this is the way to go. It's obviously more complex because it's going to be disruptive. But if we understand that we can do a lot of things without being present, it doesn't mean we are not going to do the rest on presence, but we are just trying to start the training, begin a lot of things that could be done just by distance with the right technology, okay? So what we have nowadays? Nowadays, we have some hybrid operating rooms. You have seen some augmented reality microscopes. I've seen a few of them. These are very interesting things because these are real-time, highly magnified anatomy, and you can use fluorescence, you can use anything on the anatomy, and you can project anything. You have in cardiovascular, you have these hemodynamic suits that we use them, okay? I don't wanna forget, and I wanna go a little quicker because still have a few things to talk about on the robotics, because something that always jump into our, the questions that we have, okay? Basically, a robot is something, power device, okay, computerized control that manipulate instruments and perform some surgical task. Somebody behind them gives an instruction and it performs the task, okay? That's basically what we have as robot. And these are part of the indication where we have used robots in right? I would say in the ENT area, okay? And as you know, probably one of the most popular things has been the thyroid gland. And this is something that has been migrating from, you know, transaxillary approach, retrotemporal approach, transoral approach, you know, the robots have changing the way they approach the thyroid gland, but it has been a very popular thing. And again, we still struggle with some of the economics of the robots, but the thing it is important to know. So what has been the robots in the ENT? So if you see the way in 2000 it was approved for laparoscopic surgery, in 2003, you know, started the tours with animals, and I don't want to jump into that, but I just want to show you that we have different robots. You've heard that the Da Vinci start with, you know, the prostatectomies, and then start doing laparectomies, and start doing thyroidectomies. So the thing is, our robot was doing a lot of tasks, and that was the way to cover the robot price, okay? Because the robot was multifunctional and has the capacity to be used in different kind of settings and surgery. But the robot, and even that one, it's very limited, okay? You have 4 arms, big arms, and you don't understand how those 4 arms are gonna interact in such a small, you know, space like the nares or anything that you wanna do transoral. So there's a limitation. So technology has improved, thank God, okay? And nowadays, we have better things that have moved and improved things, okay? Basically, I'm showing you here part of the, you know, these are normal situation for a robot. I don't wanna, here you see the 2 arms. This is nothing new, but the robotic surgery has advantages. And one of these advantages is dexterity. You know, you don't have this shaking hand. You can have a rotation things. You have different tools. You have a 90-degree articulation. So if we take the right things from the robot, could have some advantages, okay? I'm not saying that I think this is something. We're talking about innovation, remember. I'm not talking that everybody needs to have a robot. That's ridiculous. We're talking about the new things that we're gonna hear in the magazines and things like that, but that someday, okay, probably are gonna be more popularized because this is the way things happen, okay? So what are the advantages? Probably having a 3D binocular visualization, okay? Better ergonomics for the surgery and elimination of the tremors. You can rotate, we can have telepresence, we can have telementoring. These are the good things. And you know, that's a picture that I love when we are training on the robot, you know, doing a dural suture placement, which is, as you know, very hard, very difficult. With a robot, it's easier task, okay, because of the rotation, kind of things like that, you know, it's even hard to put a suture into the nose. In the dural area, it's even more difficult. So robot has a lot of advantages, but has disadvantages. The fact that the multi-port, you lack a lot of drill, you don't have the haptic feedback, you don't touch, you don't know what you're touching, you don't know the texture of the things, you don't know what is hard, soft, you don't know what you're dealing with. You are not actually, we don't have augmented reality, and we don't have the microscopic imaging. So these are the approaches used by the robot: transnasal, transoral, transcervical, suprahiatal, okay? And these are typical, and I like this approach very much with the robot, because the sublabial approach, it is very interesting, because now we have a wide space that doesn't create any kind of scar externally. And most of the important things, we have a bilateral approach. And I think it's very interesting to take that route in order to get deeper and having the ability to have all the advantages of the robot, having that approach. I think it's pretty interesting, okay? Obviously, we can take on different directions, infratemporal, skull base, whatever kind of things. So the next generation of robots are trying to solve the problems about the length, about the articulation, about the 2 hands. I mean, we're trying to use less space and try to bring more things into the field with less space. That's basically what we have. Let me just go a little bit. This is the next generation of tools. So you have 3 or 4 instruments in one hand. You have 360 rotation, and now you can deal with, you know, nasopharynx, larynx, pharynx, et cetera, et cetera. So that's a very interesting tool, having everything in one space. And I think this is basically what we need to look at. And again, you need to move your scope. You don't want to be in front just hidden by your instrument. Your scope can move and have perspective what you're doing and how you resect. And you move from one side, you want to look at the other side. Exactly what we do with an hard, with a rigid endoscope. So these are the things we need that needs to happen with these tools, okay? On the other hand, we have next generation here too. So these are the ones that angle. And that's a very interesting thing because they can angle and they can go around, they can bring a scope, they can be few arms, they can get into the larynx, they can go into the esophagus, they can resect lesions, they can, and they can rotate from one side to right to left, anterior, posterior. That is one of the most interesting things that we're seeing on the future. That flexibility plus multifunctionality, everything condensed in one thing. But again, we still have, we're trading, like everything, trade-off, okay? You are doing a lot of things with one thing. You don't have in tremor, but you don't have the haptic sensation that we used to have. So they're kind of things that has to improve in order to really get into the proper things. So I think next generations are really, really, really gonna improve a lot of things, okay? And the robotic, we still struggle with the economical part. There's ethical issues with the robot. Is a machine nowadays, there are steps in the machine that are programmed in the machine. So how do we allow a machine to do something that a human has to be there according to the situation? You cannot leave the machine to do anything that you don't control. And this is a very important ethical thing. And again, the trend is miniaturization and versatility of the robots. That's the most important things. And if we bring to the robot augmented reality, navigation, and haptic feedback, that's gonna be ideal. And this is what things have to go to. I don't wanna forget, in order to be on time, just to talk about the printing. Printing, it is excellent. Excellent, excellent. Printing might solve too many things. Not only when you have to reconstruct, the cranial cavity, or you have to, to reconstruct a tumor where you want to get people trained, you reconstruct the whole anatomy of that patient, but also something that we're seeing more and more with a lot of interest is reconstructing instruments. Having the instruments just construct during the surgery for the case adapted to the anatomy or the circumstance that you have in one patient. That is something that is coming. We're seeing that trend coming. It is getting very important. And obviously that's gonna be a huge change. If you're gonna program your 3D printer before the surgery, it's gonna create the instruments according to the surgery. You don't have sterilization problems, whatever. You're solving a lot of things probably, but on the other hand, you're adapting these to the anatomy of the patient, which is wonderful too. That's gonna be a tailored surgery. That would be something. I mean, I don't intend to do that or imagine that it's going to happen always, but that could be a solution for a lot of problems that we have in some circumstances. And I want to end up with something a little more easy, simple that we're dealing right now. And I just brought to you this. This is part of the ideas that you can Google it and you will see in the internet. We have COVID, and guys, you have patients, and guys, we're doing more and more office-based procedures. So how do we deal? How do we protect ourselves? I mean, that's a protection for a surgeon. I agree with that. You can get a HEPA filter with the paper mask, whatever you want to do, but this is a very heavy tool, and you really want to filter. And we know that a visualization could happen. And the patient a priori, he's positive, so you should think that way. So there should be some ideas, and this is not the time to share ideas that I receive all the time, but people to, put on the patient in order to do some procedures or to protect the surgeons in order to be, facilitate, to be protected, but to be covered. He doesn't want to get contaminated. This is the kind of things where innovations, we need to incorporate those innovations on our day-to-day. We have a situation now. We have a situation where we can create something at this point based on the things we have, because we have a new circumstance. So try to find out that innovation sounds a big thing, and you Google here and there and you find things, and I'm just putting things, a lot of ideas here, but there are innovations that we can bring on the day-to-day to our problems that we have in our office, in our surgeries, in things. So innovation is not a big word that is just reserved to the big companies, but it's something that everybody has the potential to bring those ideas to life and to share those ideas, which I think it's part of the way to find out which are the good ideas. So basically, guys, I am just right on time, okay? And I just wanna bring you these ideas and went through what I think are the most relevant things. I didn't touch on the genetics because I put 25 slides on the genetics. I say, come on, this is not bringing us to nothing. We know that we have the way to find a lot more through the genetics. We have a lot of ways to control some of the genetics, but again, I think this is a subject on its own that we need to see it and develop, and it's super interesting, by the way. Thank you.
Nice, Enrique. Congratulations, we really appreciate it. It was amazing presentation as usual. Congratulations. So we have many questions, I think. So I would like to begin inviting Professor Nilvano Andrade from Salvador, Bahia. Nilvano, thank you for sharing your experience with us. And I'd like to ask you to make some questions or comments about Enrique's presentation. Thank you for being with us.
At first, we are reading me. That's okay? The sound?
That's good.
Perfect, perfect.
At first, I want to thank you about Jacksonville for the course. It's a fantastic course. And I have a brilliant presentation. And I want to make some questions. The first question is about your last slide. Is how you, in this moment, what do you do about the situation? We are now a big problem in the world. No? What do you think we have to do in many things? For example, the first, how to say we have no money now. What the people in the United States, in Brazil, have to recommend to do? This is the first question about what you said recently. But another question is, in this situation, how you make the surgery, for example, tuberculum cell meningiomas, and you change the way in these innovations, you change the way to make surgery, or you think it's will not be?
Okay, Nivaldo, first of all, good to see you again, and thanks for your question. Okay, let me see if I catch the first question. You were talking about, probably this is what I understood.
Yeah.
Go back to reality, okay? Money is an issue, and we are, a lot of things we're talking about, this is not reality in our countries. Is that right, what you're saying? Okay, so yes, I think that innovation, we have to understand that innovation, it's something great, but innovation is a step on getting new technology. This is the way I see it. So innovation is something that, whenever you're starting with a procedure or something new, this is something sophisticated. This is something that needs, first of all, somebody to have the courage, the experience, the money, the circumstance, the infrastructure to deal with innovation. And I think that innovation has to be proven through the time. And when innovation has been proven, it's more adopted. And when it's adopted, the prices go down. And this is when I think that we have, and that's the way we see it. You remember the first cell phones. I remember somebody telling me in 1990, whatever, 1 or 2, or I can't remember, when 96, talking about the cell phone. I say, no, come on, this is stupid. Why are you gonna need a phone? I have a phone in my house. Okay, I didn't see it. It was expensive. The technology wasn't good. And then I don't know anybody in the world that doesn't have a phone, okay? This is something that I couldn't imagine myself. I think technology at this point, the innovation that we're showing here, because we decided to have this lecture on innovation, on things reserved for, you know, the big guys. Okay, these guys, what are they doing around this? But that's why I want to just point it out. I agree totally with you. Okay, we have to be grounded on the earth and understand that a lot of things that we're talking here has, you know, it is totally selective at this point. On the other hand, on your question, your second question was around the NIRAF and the technologies that we use.
For example, a sex approach for meningiomas, for example, cellular meningiomas, stellar meningiomas.
And you were saying it is about the NIRAF technique, the near infrared technique. Okay, that's an interesting thing, because yesterday I had a long conversation with somebody in a university here in US that was the one who developed this near infrared technique, and he started like in 2000, and he hasn't been able to make that project go farther enough until now. And we were talking about another field. We were talking about parathyroid gland. Okay, we were talking about another subject. And again, it took him almost 20 years to incorporate, to have the FDA approval, the clinical things, and all the things. At this point, when they started launching this, it was a super expensive project and nobody has the technology. Nowadays, it's something that the prices has been going down and it could be used. But again, I still believe that we're not there yet. Things have to happen in order to, and I've seen that the NIRAF technique in big academic centers. I haven't seen that in any practical individual surgeon in the world, okay? That hasn't happened. So to your point, yes, academic.
Thank you, Nilvano. Now I would like to invite Maria Júlia from Minas Gerais, Belo Horizonte. Maria Júlia, take your time. You have.
Thank you, Leo. Enrique, congratulations for your presentation. You didn't talk about 3D endoscope. What do you think about 3D endoscope?
Very good. And as you know, Maria Julia, you have been here in Jacksonville with us, and I think that you were one of, as you know, in our courses, we use 3D endoscopes, yes. And we do the demonstration with 3D endoscopes. And I can tell you that here in my monitor, on your right is Aldo. Okay, so Aldo has been we have been dealing with that. And I remember Aldo telling me, Enrique, this is too heavy and too big. And it is exactly that. I mean, I love to show people on 3D thing, but it's a huge thing, a heavy thing. So Rick Rao uses a 3D endoscope, but he doesn't use it all the time. He uses it a lot of times, but not all the time. When he expects a long surgery, he does not using it. So it is something that again and again, guys, innovation is a trade-off. You want to use something new, but it's not at the level of something simpler time to time. So it is that the point is too expensive. It's probably bigger, heavier, and you have in a 3D perspective. At this point, I think we need to improve even the 3D image, because I don't think the depthness is doing much. When we bought this very expensive equipment we have here, I thought that was gonna be very good for the younger guys. They don't have the 3D perspective, they just have one eye, so probably they will see the anatomy and now they can go with a normal scope. I don't think, after 5-7 years with that instrument, and I got the new generation now. I wouldn't say I'm totally convinced that this is something that I would do it again.
Right. Thank you, Maria Júlia. Now I would like to invite Camila Meotti from Rio Grande do Sul, Porto Alegre. Please, Camila.
Hi. Good evening, everyone. First of all, thank you, Dr. Aldo, Leo, and Camila for the invitation. Thank you so much, Dr. Enrique, for your lecture. I'm really delighted with it. We had so many new and nice information, so thank you very much. I was thinking during your talk about in the last 10 years, when you go to rhinology congresses, we heard about robotic sinus surgery. Generally, in the end of the talks, like a perspective to the future. And now, 10 years later, it's still the same, for me at least, and here in Brazil. So my questions for you is, do you use it in any cases or in some cases, and which cases? And the second question is, would you encourage like rhinologists to train it now? Do you think we are going to really need it in the next 10 years, for example?
Thank you very much again, guys, for these all great questions. Camila, you too. Thank you very much. Camila, let me just give you my perspective. These are very personal perspective. I think at this point, I mean, if you compare the practical thing, and that goes all to what Nilvano first asked, okay, are we grounded? Do we need really to get a robotic to do a thyroidectomy, somebody that does, 10 surgeries for 30 years? I don't think at all. I don't think that this is something that is required at this point. It has become, time to time, we have to be wary about getting fancy, because that becomes a marketing thing, and we lose what we are original. And I think that an experienced person that has the knowledge, has been trained one way, doesn't need to get into this very complicated. And I'm trying to think about the answer, because you asked me something very difficult. Do we need to start training people, the younger ones, because that's going to be the future? I'm not seeing. I'm like you. I'm not seeing a quick evolution on the robotics. I haven't seen. If I have books from 2000 on robotics, and I haven't seen big evolution. Things are coming very slow. So is this generation that is going to use? I know that, in South Korea, all the thyroids are doing by robotics, and around the world, we have like 1 or 2% of the head and neck surgeons doing robotics for thyroid. But this is something I still believe we're far from it. And by the way, I'm really interested in robotics. Medtronic has a robot, okay, but it's for spine. It's Mazor, it's a totally different thing. And I'm totally passionate for robots. But the truth is, we have to be sure when we are in the process of evolution and we're academic and try to find things, or to use it. If your question is about using, I don't see it any close nowadays in our countries, anything like that.
Okay, thank you very much. I totally agree.
Thank you, Camila.
Thank you.
Thank you, Camila. And I would like to invite Ricardo Dolce from Santa Casa de São Paulo. Please, Ricardo.
Hi, everyone. I'd like to say thanks to Camila, Leo, and Professor Augustin for the invitation and of this great team. It's really a pleasure to be here. I'm glad about it. And Professor Iturriaga, again, it was an outstanding lecture. Congrats, it was amazing. I learned a lot tonight. Thank you so much. And I had a question that you showed a lot of new technology for the education. And in my opinion, the many colleagues, the dissection is the best way to learn and to improve the skills to perform a surgery. Can you see some way to merge both the virtual technology and the dissection to improve more the education for the resident and to the other ENTs and other doctors? Can you see this situation? Because it could be perfect.
Totally, Ricardo. Ricardo, I'm going to throw you that question back to you. And I'm going to throw the question back to you because I'm actually in this moment, I've been like 3 months in my house, okay? I'm frustrated, okay? And this frustration is how I am gonna teach people, because we have a super lab here, we have everything, and I'm not allowed to do that. So that question goes back to you. How do I do what I need to do, which is, you know, teach people without being able to be there. So I agree with you. There's nothing better than a cadaver. There's nothing better than being in, you know, struggling. You don't know how to put your hands. You don't know how to do that. And you start learning little by little. And how I'm going to teach that? So I believe, Ricardo, that this is probably a situation where we're going to accept the situation right now. And, you know, it's a situation now that we have probably to understand that the world, I think the world is going to come back, but we'll learn some changes. I don't think we're going to have, last year we have 1,500 surgeons here in the different courses we have here trained. I don't think we're going to get less, you know, more than 150, less than 10%. People are not want to come. They don't want to spend money, time, risk, or whatever. I think things are going to change. They're going to come back, but very slow. So to your point, because this is philosophical, my question, but to your point is, we were expecting that there might be better ways, but again, not for all the education. Now we're going to fragment the education. This is what we have done here. We have fragmented the education from some basic concepts. So I'm just going to give you something, a little taste of flavor. I was here in my same place here, and I didn't have the special lenses, but somebody was showing me in my iPad. They project from somewhere in Europe, they were projecting some anatomy, virtual anatomy, and I was playing here, and we were playing, the guy and I, against his model, okay, in the air. He couldn't find where the uncinate process was or whatever, the stock of the pituitary, and I could show on his virtual glasses in his room, okay, I could play on that. So probably we can start teaching people elsewhere anatomy, some general surgical principle things, but obviously we need to have cadavers. There's nothing like a dissection. I totally agree with you.
Thanks.
Thank you, Ricky. And Fabrício, please. He's ENT surgeon with large experience in Santa Maria, Rio Grande do Sul. Thank you, Fabrício, to being with us. Please, your question.
Thank you. First of all, I would like to thank you, Dr. Aldo, Dr. Camila, and Leonardo, and everyone. I'm very happy with the invitation. I would like to congratulate Dr. Iturriaga on your inspiring class. Thank you so much.
Thank you.
I have two questions. The first, about how you see the future of endoscopic sinus surgery in the perspective of immunobiological drugs. And the second is about computational fluid dynamics in nasal surgery. Although it's not a new thing, do you believe that this tool will become an important tool in daily practice?
Can you repeat the second one? Sorry, I couldn't hear.
About computational fluid dynamics.
Oh, okay. Very nice.
It will be an important thing. It's not new, but it would be an important thing in daily practice.
Okay, let me go back with the two questions are great, okay? And it really are the trends on the investigative part that we're doing. And I had on both of those questions, I had different slides that I hide, okay? That was a long presentation. But for instance, I should have at least left, and that's my fault, one of, you know, these monoclonal antibodies, the dupilumab, okay, which is actually part of the treatment. It was approved here in US in 2019, and it has like skyrocketed now. I mean, a lot of people are using for CRS with polyps, and it has a, you know, an interesting response on those patients. And that's something new. That's something new. But again, it's a monoclonal antibody, okay? And it's, I think it's chimeric. So, you know, chimeric monoclonal antibodies are part of a rat, part human. It's a mixture. and has a lot of side effects time to time. So I'm not sure that anything of the things that we're doing, first of all, this is something which is super expensive. Secondly, I prefer, and that has always been part of my, my point, I prefer to see more results, more time, more things before having on my own or my patients. Okay, that's something that it should be a rule for all of us. Okay, and so again, I don't think we have even the long term, because one of the studies have shown that yes, the long term for them has not been a long term enough. So the recurrence of a polyposis, probably we have spent a lot of money and then we're back to the surgical option. So I personally prefer to wait a little. That's my perspective. On the other hand, I had a presentation, yes, on any single diagnostic technology or any new tool has, again, the trade-off of the price. And you have really to understand that if you want to really be one of the leaders on that academic studies, on those scientific things, that's a thing. In our countries, we have a massive amount of patients with no capacity, with no resources to do and treat these kind of things. I don't think we should, just accept the reality. We should push that to a better thing, but we have also to be real. We cannot do sophisticated things, studies, treatments, because this is totally out of the context. Okay, I believe in Brazil you have great centers that might trying, kind of doing these kind of trials, but I don't see these. Your question was on the day-to-day. Do I see these computers, or I see the monoclonals, or do I see anything of these kind of things new to be incorporated shortly? No.
Thank you.
Thank you, Enrique. We have a question from the audience about navigation. In Brazil, it's not our reality. It's difficult. We should have this for our daily surgery, but it's impossible. Due to many questions, especially it's really nowadays for health insurance, it's a high cost, it's very expensive. We think in the next 10 days, the same question Camila made, we're gonna have this navigation in our daily, especially in the South America, Venezuela, Colombia, Argentina, and Brazil. We know you know all these countries very good. What's your opinion about navigation next 10 days?
Next 10 years or days? 10 years.
10 years.
10 years. Okay. That was a short time. Okay. On 10 days, I don't see much more change. Just kidding. No, the thing is, yeah, that's incredible, because we have been turning around the same situation, and that's reality. Okay. We have to divide perfectly when navigation becomes really something that might help. Okay, that's something that we need to really focus. But again, our countries are a big majority of people with no resources. And as you know very well, guys, we have a very small group that has resources, and they get time to time into all these marketing thing, and they jump into that. So what I've seen is, if you ask me, I would love to tell you that I see that navigation is something that it is actually at this point is very good, but I don't think it should be used for all the circumstances, because you and I, guys, we know this is not correct. This is not even, you don't have to charge anybody for something that you don't need it. There are circumstances where it can help, but I also think that navigation has to improve. I also think that, and this is where we're heading, navigation has to have a more real-time information, and we're looking for that. We're trying to find out the way we're gonna bring navigation to a cheaper price, a more real-time situation. This is where navigation per se, the technology is doing. But about us ENTs using the navigation in our countries, I would say, obviously, only when it has to be used, And I know where you're heading with that question, Leo, because that question goes to, we have heard that in other countries, they, for every case, use navigation because they have looked at their numbers, their statistics, and they found that when they really need the navigation, if they're not trained enough, that's going to be a complication almost because nobody has the experience to use the navigation. It has been shown in many studies. I think this is a very valid study, but this is not our reality. I don't think this is something we can extrapolate into our countries because this doesn't go to the reality of our countries. And we have to be clear on that. There is no question around that.
Great. I have a personal question for you, similar as Ricardo Dolci. Last 2 weeks, me and Aldo, we are discussing very close about the future of Congress, especially our Rhinology Congress, like a brainstorm. What to do to make people to take a flight and come to São Paulo, around 1,050 and 500 persons together in a Congress all together seat for 3 days. And after especially these lectures like yours and round table, we can see we can learn virtually as these. So my question is, we need your opinion, how to bring people, because we love these to find people to discuss cases and share experience. Do you think this will take part, these kind of lectures, you take part of the Congress? And more than this, how to bring hands-on or bring Congress more people just sit and watch, or something like a Congress and the audience can put their hands to get more skills and surgery and daily office treatment, everything. Do you think of 3D models can take part in this situation? What do you think about this? We are discussing this for the last 10 or 15 days about the future of this.
Yeah, I think this is a time to rethink about it, because when we had both choices, you have cadavers and you have 3D models, obviously, you get the cadavers. But nowadays that we have this circumstance, I think this is a time to rethink about that kind of model. What I'm seeing personally, there are a few things. Let me just try to summarize what I've seen. When we start in the March, that was March, here in US, we tend to have like, and personally, we tend to have like 5-6 lectures a week or 7. That was crazy. April going up, and June, we have been coming down because people are returning in a very moderate way to their office, but their head is back and they're busy, and we have slowed down this kind of interaction lectures on the afternoon. Okay, so probably now we're at 1 or 2 per week, and in US that's and even if you see the people that connect, we used to have 1,000 people, now we're having 100 people, and we're seeing that trend because people are trying to bring things to normal. And I'm telling you that because you have that doubt that I have too. Are we going to return exactly the same way to normal or not? I don't think we're going to get exactly to the same point, even if we have the tendency to go back. Okay, that's a totally human thing. And I think at some point we should, because we have the lab here, I need you here, guys, and we want to bring it back. But I think that it's going to take a while. And since Aldo, for instance, he postponed his course few, and all the congresses are postponed all around the world. And I have attended, I attended this morning to a conference that's in Romania. And, that conference was supposed to be a 3-day thing. It's going to be in 2 days, and we have 4 hours, 4 hours every, 2 days, 4 hours. These are the kind of things we're seeing. To your point, how do we dissect? How we teach? I think part of the teaching could be, you know, the very theoretical part of the teaching. We have now to divide the teaching. One part could be digital, very good. New technology, new 3D, that's gonna be around the anatomy, whatever. But I think that we need to have real, you know, situations. And I think that probably before the cadaver, we're gonna get on the 3D models. We're gonna get back to the 3D models. I believe 3D printing is improving. I believe materials are better. And now we can mimic, but I think the models are gonna regain a lot of interest. And we're seeing that in Australia, for instance.
Great, Enrique. That's all. Professor Aldistam, your words.
Yes, thank you, everybody. My dear friend Enrique, it's really fantastic. After almost 1 hour of your amazing lecture, you can summarize years and years of research in just 1 hour. It's really fantastic, the capacity of summarize many things. Of course, from these innovations, some of them you can use it immediately, some of them you can wait and to use later. So anyway, it's important to know all these innovations are in development and you can use it practically in our office, in our surgical theater, etc., etc. So thank you so much, Enrique, for joining us tonight. And thank you very much for all the panelists. I'd like to thank very much to the Brazilian Society of ENT for supporting us, as well the Brazilian Academy of Rhinology. I'd like to thank very much Camila, our coordinator, and Marcelo and his team from Gravação. Marcelo is our company of translation. It's really fantastic. It's a very nice job. Thank you very much, Marcelo, for this wonderful job. Please, Camila, back to our Rhinology. As I mentioned before I start the meeting, the lecture tonight, and Enrique mentioned during his presentation, we postponed our Rhinology meeting 1 year. The initial idea were to have this meeting next year, in May next year, then to postpone almost 1 year in order to observe the evolution of everything. So the question made by Leonardo was really a very good question, because how to do to attract the people to come to the meetings. So you need to do something more practical maybe in order to attract the people. So this pandemic time give us a nice opportunity to have these wonderful lectures without moving from your house. So it's the good part of the pandemic situation. But the worst part, you can see the people personally. So it is very good, especially for us Latin American people. You like to stay together, like to stay confraternization, etc., etc. To drink a Scotch, to drink something like this together, I think is really, really very, very important. So this was postponed to next 2022, and we will inform all of you about this. Again, thank you very much to all the panelists. Thank you very much to Leonardo for moderating this section. And very soon, we will inform you for our next international ENT live stream. So having no invite confirmed tonight, but maybe tomorrow I will inform of you. My dear Enrique, have a good time, safe. Thank you very much. My best regards to your family and all the group of Medtronic Company. See you.
Thank you very much, guys. Thank you very much. Have a good night. Thanks a lot.
Everyone.
Night, everyone.
Bye.
Bye. Thank you.
Bye. Thank you.
Bye.
Thank you very much.
Bye.